All right, I'm getting ready to enter the room. Good morning. I'm Linda. I'm the nurse that's going to be taking care of your baby. I'm going to do an assessment of the baby. Let me wash my hands. I'm going to put on some gloves. And I can see by looking at the ID on this baby that this is baby Carrie Mannequin and ID 13579. That matches my doctor's order. Let me provide some privacy, and we're going to start this assessment. As I'm looking at the baby, I'm noticing the color of the baby, and the lips are pink. I see no circumoral cyanosis, and this means that the baby is well oxygenated. I'm looking at the respiratory rate at the abdomen, and I'm seeing that it is rising and falling, and I'm counting it for 1 full minute, and I'm getting a rate between 30 to 60, and I'm going to say that this respiratory rate was 40. I'm looking at the respiratory effort. To do that, I'm looking at the abdomen and chest. They are rising simultaneously. I'm not seeing any intercostal retractions between the ribs. I'm not seeing any nasal flaring, and I'm not hearing any kind of expiratory grunt. So this baby's respiratory pattern is unlabored. I'm looking at the activity, and this baby is awake. Again, all of these are good indicators of a well-oxygenated baby. And the last thing I'm looking at is the P, the position of the baby. The baby is laying supine with the right hand flexed. Left hand is not flexed. Normally, I would see flexion of all extremities, and that would indicate well-oxygenated. The fact that this is asymmetrical would make me question any kind of neurological damage. I'm now going to start and work my way through my assessment head to toe. First thing I want to do when I touch the baby is to get the apical heart rate. And I'm going to place the stethoscope right over the left breast. I'm going to count for 1 full minute. It should be between 120 to 160, and I'm getting a rate of 140, and it is regular. I may hear a murmur. This baby's only 1 hour after birth. That would still be considered a normal finding because the fetal shunts are still shutting. While I've got my stethoscope, I'm also going to assess lung sounds. I have a fairly small diaphragm, so I'm going to listen to the upper lobe through the inspiratory and expiratory phase of the cycle. Both sides, upper lobes. I'm going to listen to the lower lobes. I'm going to listen underneath the arms. And I'm also going to listen posteriorly, upper, and 4 places on near the spine, not over the scapula. And I'm hearing clear lung sounds. This was a vaginal delivery that received a thoracic squeeze, so I was expecting to hear clear lung sounds. If my diaphragm was very large, I might could accomplish this in less than 4 movements on the chest. I'm also going to listen to bowel sounds. I'm going to listen to the upper and lower quadrants of the abdomen, listening for peristalsis. And I do hear active bowel sounds, and I would expect to hear them at 1 hour of age. If I have a larger stethoscope, I could just listen to either side of the umbilicus and probably hear the upper and lower quadrants simultaneously. I'm now done with my stethoscope, and I'm going to start the assessment working head to toe. As I look at the baby's head, I'm noticing that I don't see a cephalohematoma, which would be a large knot on either side of the head that would not cross the sagittal suture. I don't feel a caput succedaneum, which is just generalized edema. It does cross the sagittal suture. As I feel the fontanelle, the anterior fontanelle is a triangular shape. It is soft and it is flat. No indication of increasing intracranial pressure or sunken would indicate dehydration. At the back of the anterior fontanelle, I want to follow the sagittal suture till I get to the posterior fontanelle. It feels like an upside down triangle. It is very small. It is soft and flat, and those are all normal findings. I also want to just look at the scalp and see if there's any abrasions or lacerations, and I'm noticing that I have individual fine hairs covering the baby's head. So this looks completely normal. Now I'm looking at the face, and I notice that the face is symmetrical. And I want to run my finger down the bridge of the nose, and I do not feel any fracture that could happen with a vaginal delivery. Occluding one nary, I see that nary, the opposite nary, opens and flares, indicating that it is patent. And then occluding the other nary, I see that this opposite nary flares, and so the nasal passages are patent. I can also check for the color on the tip of the nose by pressing, looking at the color of the blanch, and I see no indication of jaundice. Looking at the eyes, I see no drainage. I see no edema of the eyelids. If I did have edema of the eyelids, I know that would be normal from pressures of the vaginal delivery. And I'm also looking at the sclera, and it's white, no indication of jaundice. And the conjunctiva is nice and pink, and I don't see any subconjunctival hemorrhaging, which would look like dilated blood vessels that have pools of blood. And that comes from pressure also as the baby goes through the birth canal. Looking at the ears, I'm looking at the outer canthus of the ear and imagining a horizontal line, and it would cross the pinna of the ear. So these ears are not low set, which is a genetic finding that you might find with a Down syndrome child. I'm also going to check the cartilage recoil by folding the earlobe towards the center and then towards the front, and I see that it springs back with a quick recoil. This is a good indicator of gestational age, so this baby has a term appearance. I'm going to look for a skin tag that might be in front of the ear, and since the ear and the renal system form at about the same time gestationally, if I do see a skin tag, I expect the doctor will probably order renal scans. I can also look for any pre-auricular dermal sinuses, which are like little pinpoint holes in front of the ear, wanting to make sure that there is no drainage from either of those holes if I saw them. I'm going to look at both ears, the same findings, looking for the position of the ear that is not low set, cartilage recoil, looking for skin tags, looking for pre-auricular dermal sinuses. Looking at the lips, I do not see a cleft palate. I'm going to stroke the cheek, and the baby turns his face towards the side that I stimulated. That is a positive root reflex. I'm going to take my finger and insert it in the mouth and start at the hard palate, feeling, and then go all the way back to the soft palate. I'm feeling for any kind of cleft palate, and I'm not expecting to feel any. And while my finger is in there, I'm having a good strong suck reflex. So I've tested two reflexes, the root reflex and the suck reflex. As I pull my finger out, I just want to press down, looking at the tongue. The position is midline. I see that it does cross the gum line, that the frenulum is not tight or short, causing the baby to be tongue-tied. So there should be no interference with breastfeeding. I can also look for Epstein pearls, which are on the gum line usually, and they are white patches. They're a completely normal finding. I don't see any. I could also look for thrush. I don't see any thrush in the baby's mouth, which is a fungal infection if mom has been on antibiotics. I'm looking at the nose and the chin to see if I see any milia, which are little white sebaceous glands that are still not open, and I don't see any on this baby, but they would be a normal finding. Looking at the neck, I see the trachea is midline. I don't see any webbing of the neck, and I've already established that I have good range of motion of the neck. I'm going to palpate the clavicle since this is a vaginal delivery, and it feels intact, and I have noticed that the baby's been moving the arms, so that's a good indicator that I do not have a fractured clavicle.